안녕하십니까? 이종훈 치과
Greetings.
손영희입니다.
I'm Dr. Son Young-hee of Kunpo-E Dental Clinic. In this lecture, I'm going to talk about immediate implant placement following the previous lecture. I'm going to talk about three-dimensional position of the implant and how we should manage gap. When we do immediate implant placement, the position of implant is a very big factor in determining success of immediate implant placement. In the previous lecture, I've talked about how tissue changes after extraction and immediate implant placement. I talked about how immediate implant placement could lead to less changes compared to delayed placement. I would like to talk about another study by Botticelli. If you do immediate implant placement and if the gap is approximately 3 millimeters, then there's a spontaneous healing. We need to be careful here. Although there's spontaneous healing in gap of less than 3 millimeter, however, you need to consider the remodeling that occurs on the buccal side. It does not mean that you do not need to do gap filling because there is spontaneous healing. I talked about this in the previous lecture, but by doing bone augmentation procedure, you can prevent horizontal bone loss somewhat. Therefore, you need to do gap filling in most of the cases. If you look at the measurement of buccal plate resorption, horizontal resorption occurs approximately 50% on the labial side. When you do gap filling, this is internal socket graft. By doing gap filling, you can overcome these resorption. If the implant is placed more towards the outside, you can do external socket graft as well. Horizontal position of the implant. When we make a determination on this, where should the implant be? In most cases, the further away from the buccal plate, the better. However, if it becomes too far, then it can be a problem when making prosthesis. Buccal side of the implant may be over-contoured and there can be lateral force caused by the prosthesis. Therefore, there needs to be at least 2 millimeter of buccal plate. Distance of 2 millimeter needs to be secured and determine the horizontal position of the implant. If you look at these cases, if there's a socket from the buccal wall, the implant needs to be distanced from it. I'm going to show you my case. You need to distance the implant from the buccal plate so that implant is not exposed due to remodeling. The minimum amount of distance is 2 millimeter apart from the buccal bony wall. That is recommended. After you determine the horizontal position, you need to do internal graft. This is a must-have to prevent remodeling. Let's move on to vertical position. A lot of people experience difficulty in determining the vertical depths when doing immediate implant placement. The reference point for vertical position are approximately 4. CJ of adjacent teeth, marginal gingiva, proximal bone crest, and labial bone crest. If you look at this case, in the first one, CJ of adjacent teeth, if there is a gingival recession in adjacent teeth, CEJ of adjacent teeth is exposed, so this is not a stable reference point. In the case of marginal gingiva, when we elevate flap, you cannot reference it. In the case of labial bone crest, if there is damage to the labial plate, you cannot use it as a reference. In most cases, the reference which we can use most stably is proximal bone crest. You need to determine the implant's vertical position using proximal bone crest. That is the most safe way to do it. How inferior should the implant be from the proximal bone crest? In my opinion, it needs to be 3 millimeters at least inferior to the proximal bone crest. You may think that it is quite deep. There are many different factors that determine the vertical position of implant, gingival thickness, and so on. We also need to consider, after healing is done, biologic width refers to the amount of tissue attachment supracrestal to the implant that is formed after healing. You need to consider that. In the case of internal submerged type implant, there are many problems when placed shallow, but there are not that many issues when placed deep. So placing it deeper is more ideal. In my case, I think 3 millimeters is good. There's a little bit of vertical bone loss. I assume the vertical bone loss to be about 1 millimeter. So I think it is better to place it 2 millimeters deeper. In conclusion, I place the implant 3 millimeters inferior. In this case, I placed it deep, 3 millimeters below, 3 millimeters from the proximal bone crest of adjacent tooth. The implant is placed, bone graft is done, healing abutment is connected, collagen membrane is used to cover it, and surgery was completed. This is post-op panoramic image. This is oral cavity and CT. If you look at CT, labial bone augmentation amount is not that significant on CBCT. The hard tissue looks slightly distorted, but let's take a look at the result. This is after healing. In my case, I provide the prosthesis 16 weeks after surgery. This is CT at the time of prosthesis delivery. This is panoramic image. At the time of prosthesis delivery, you can see ideal contour and ideal buccal bone. This is panoramic image after 4 years. Bone remodeling has occurred on vertical bone, and you can see very stable bone response. If you look at CT image of number 14 and 15, labial bone is well maintained. In immediate implant placement, vertical position is very important. As shown, from the bone level of adjacent teeth, you need to place it 3 millimeters inferior to that. How can we make the decision? When you open flap, we can make a decision very easily. We can determine the vertical position very easily. However, if you do flapless immediate implant placement, how can we adjust it? In the case of Austin, there is pre-mount implant. You use the length of pre-mount implant to determine the vertical position of the implant. As you can see, up to the point where a mount driver is connected, the length is approximately 4 millimeters. You need to utilize this to place the implant deeper, so 3 millimeters to get stable vertical position. As shown, you need to place it deeper. Then, the implant position will be approximately 4 to 5 millimeters deep. We'd be able to get the vertical position of implant more easily. If you look at the radiographic image of this implant, it has been placed in a very stable position. Now I'm going to move on to gap management. I believe it is a must-have to do gap filling when doing immediate implant placement. I do not prefer just leaving it as blood-filled cavity. If you can get a good result with that, it's not a bad idea, but personally, I think we need to do gap filling, especially in the case of buccal fenestration. This is the same with palatal side as well. If there is dehiscence defect, gap filling is imperative. In this case, you may need to do external socket graft as well. If the buccal plate is too thin, in order to limit remodeling, bone graft is necessary. If the implant has been placed too buccally or labially, if the gap is thin, you can just use it. If you feel unsure, you can do gap filling to get more peace of mind. When doing gap management, what kind of material should be used in the socket? I use FDBA, allogenic graft. I only use FDBA and I don't use DFDBA. And I use cortical chip or cortical cancellous chip for gap filling. When doing socket graft in extraction socket, the requirements for graft material are: it should not undermine the healing potential of the socket. Therefore, if it lasts longer and is not absorbed after healing, or if the absorption is slow, it is not fit for socket graft. It needs to have a scaffold effect, and it needs to be relatively resorbed early. It needs to be replaced with host bone. That is better in the case of socket graft. That's why I use allogenic bone to do gap filling. Second, as mentioned, if the labial or buccal plate is too thin, you need to do gap management and socket graft is necessary. In that case, how thick should buccal or labial plate be so that it does not require gap filling and can withstand bone remodeling? If you look at the literature from 2000, the labial plate or buccal plate needs to be at least 1.8 to 2 millimeter to be able to withstand remodeling. This study was published in 2011. It needs to have at least 2 millimeter or above labial plate to withstand remodeling or show minimal change. The ideal thickness of labial plate is over 2 millimeter. If the labial plate thickness is over 2 millimeter, and once this is confirmed, gap management can be minimized or you can forego gap management. However, in the case of upper anterior where most remodeling occurs, it is practically speaking impossible to see buccal plate over 2 millimeter. If there's no buccal plate, what should you do? You can assume that remodeling is going to occur in maximum. If there's no labial plate, there needs to be regenerative procedure to regenerate the labial plate. I think you can consider usage of membrane. Implant should be placed more palatally away from where labial plate is going to be formed. Bodily shift needs to occur. In this case, you need to use a very rigid membrane to maintain this volume. As shown, you can use titanium reinforced membrane like Smart Os Builder. These can show very good results. Osbuilder was used for this patient, and you can see that the labial plate has been overcorrected and has a very ideal contour. It looks as if augmentation has been done significantly, but once it goes through remodeling process, because in the upper anterior area, the amount of remodeling is significant. Therefore, you need to use rigid membrane and do overgraft to withstand remodeling. We need to compensate for buccal plate resorption. Ways to do this include the following. First, you need to look at buccal plate thickness. If it is 2 mm or above, you can assume there's going to be minimal remodeling. Second, you need to think of ways to do gap filling. You need to place the implant away from where the remodeling is going to occur. Also, you can consider doing external bone graft outside of extraction socket. Implant has been placed nicely here, but if you do no bone graft, once it goes through remodeling, only very thin labial bone remains, and this is something we can see very frequently. With time, labial plate is completely resorbed and the implant body can be exposed. It can be only covered with gingiva. When you do just internal graft, when you do only internal socket graft, you can prevent somewhat of a remodeling, but there's still going to be only thin labial plate left. The amount of labial plate thickness is most when you do both external and internal socket graft. You can get such very good results. You need to always consider gap filling. In my case, I think you need to do it. It is crucial. When you do internal and external socket graft, you need to think of the material as well. In the case of internal bone graft, you graft inside the socket. As mentioned, it is more favorable to use allograft. In the case of external graft, it needs to withstand remodeling, so you need to use material that are resorbed more slowly. Allograft should be used for internal graft, and xenograft and alloplastic should be used for external graft. This is called a sandwich augmentation. Allograft is used on the internal graft, and xenograft is used on the outside. What kind of criteria can we use to determine whether we are going to do internal graft or external graft or do both? Capillio Testori published this study in 2013 setting this criteria. In this study, there's this concept called IBP. IBP is the distance from the external part of the implant to the outer surface of labial plate. The distance between external implant collar and the bony surface on the labial plate. You use this criteria to determine the graft you're going to do. If IBP is smaller than 4 mm, this means that the implant has been placed more labially or that the space is tight. In this case, you need to do internal and external graft along with membrane application. The standard is 4 mm. If it is smaller than that, you need to do both internal and external. If it is above 4 mm, you need to do internal graft along with membrane application. You need to use this 4 mm as a criteria. The IBP should be used as a criteria as to how to do bone graft.
앨범 플레이트의 아우터 서피스까지 거리 4mm를 기준으로 해서 그라프트의 범위를 결정을 하시면 될 것 같습니다.
Let me share a couple of cases. This is a basic case. As for the details, I'm going to share it in the offline courses. As for this patient in number 3, on the apex side, there was a lesion and the pain was an extreme pain. Extraction was decided on CT. There's a bigger lesion on the apex side and there was post, and further treatment was quite meaningless. Post was fractured. Atraumatic extraction was done. Minimal flap was reflected. Pre-mount implant was used to determine the vertical position of the implant. In the case of single root tooth, you can get primary stability not just from the basal bone but from the lateral wall as well, so you can get better primary stability. The horizontal position of the implant. It's about the size of the implant. It is 4.5 millimeter diameter. I believe it is at least 4.5 millimeter apart. I did not reflect the flap. Internal socket graft was done. FDBA cortical chip was used for internal socket graft. Membrane was applied. 2 interrupted suture and 1 sling suture was done to complete the case. This is standard view and CT after surgery. On CT, gap filling can be observed. What kind of results will we see 4 months after surgery? This is CT, custom abutment and full zirconia crown was used. ER type, hybrid type prosthesis was connected. After surgery, this is standard view and CT. If we magnify it, as shown, you can see very ideal labial bone contour. This is 4 months after surgery, so remodeling is not completely over. Follow-up is very important. This is at 39 months, slightly over 3 years. There is slight recession. Panoramic image, standard view, and CT. On CT, labial bone is well maintained. Following IBP concept, even if you do just the internal graft, you can get favorable result. In the case of this patient, in number 15, root fracture occurred. The easiest area to do immediate implant placement is premolar. If you are going to attempt immediate implant placement, you can try starting off with the premolar in the upper and lower. I believe this will lead to better result and you can gain more confidence with it. This is how it was fractured. Periotome was used to do atraumatic extraction. This is extraction socket after extraction. Implant has been placed palatally as much as possible. In this case, vertical position was chosen. However, there was an issue. The healing abutment diameter is 5 mm, height is 7 mm. I rarely use healing abutment with diameter of 4 mm or under. If I am to use a healing abutment of 4 mm or under, then there's something wrong or concerning. In my dental clinic, I always use healing abutment of 5 mm or above. In this case, 7 mm healing abutment was connected. You can see it is submerged except for maybe 1 mm. You can see that it has been placed deep. This is essential to get good result. If you look at IBP, the gap is bigger than the diameter of the implant. Therefore, internal graft was done. In this case, DBBM, which includes collagen, was used. I try using collagen-included materials at times, but I personally recommend you use allograft when you're starting off. collagen was applied, a suture was done, and the case was closed. Horizontal matrix suture was used to stabilize graft material and collagen membrane. This is post-op image and CT. As shown, implant has been placed and it has been placed sufficiently deeply and there is sufficient amount of buccal bone. 3 months later, I connected custom abutment and full zirconia crown. Prosthesis was delivered. This is at 3 months. Panoramic image and CT. As shown, in immediate implant placement, the position of the implant is very important. Yes, it is important for all kinds of implant placement, but especially in immediate implant placement, correct position of the implant is essential, especially because there are not that many references you can utilize. That is why I wanted to emphasize it. The summary. In this lecture, I've talked about immediate implant placement, the implant position, and gap management were discussed. The vertical position of the implant should be 3 mm inferior to proximal bone crest, and horizontal position should be 2 mm away from the buccal plate. The extraction socket gap should be filled with graft material. Decision needs to be made whether you're going to do internal socket graft only or both internal and external socket graft. Depending on IBP, from the outer surface of the implant to the labial plate's outer surface, if the distance is below 4 mm, you need to do internal socket graft as well as external socket graft. If it is over 4 mm, you can just do internal socket graft and there will be no major problems. Did you enjoy the second lecture on immediate implant placement? Immediate implant placement can reduce the treatment time for the patient as well as the number of surgery. Therefore, it is easier to get the patient acceptance. In the case of upper anterior, this can be utilized along with other methods to preserve papilla. There are many benefits with this treatment modality. However, as is with all different types of treatment, there exist complications and there are factors that we need to consider. It may feel complicated at times. If you continue on this learning path and build on your expertise, you'll be able to make smart decisions for different cases. Thank you for watching.